In Shrewsbury and Telford Hospital NHS Trust, we understand the needs of our trainees in gastroenterology. I was myself a gastroenterology registrar for 7 years and understand some of the challenges that trainees face during their training. We would therefore like to share our vision of future of gastroenterology training and recommend some in-house training sessions that trainees will find useful.
Hello, my name's Mark Cheetham. I'm a colorectal surgeon and I'm also the medical director for the scheduled care group here at Shrewsbury and Telford NHS Hospitals Trust. My remit includes managing the surgical specialties but also gastroenterology and endoscopy. I believe there's great strength in us working together between surgical disciplines and gastroenterology. Gastroenterologists need to work with many disciplines including oncology, histopathology and surgeons. So one thing I'd like to propose for our gastroenterology trainees is that we do a job swap where they work with the surgical teams for a week and the surgical trainees work with the gastroenterologists for a week. This would mean that for the gastroenterology trainees that they upskill their knowledge of surgical anatomy and surgical procedures, and conversely our surgical trainees would get more exposure to inflammatory bowel disease treatment and intestinal failure.
We communicate with our colleagues in primary care mostly through writing letters. In Shrewsbury and Telford Hospital NHS Trust, we are developing a common in-house style of typing clinic letters. As a part of this initiatives, our trainees will receive a dedicated training session on constructing and dictating clinic letters. This will not only improve our communication with our GPs, but also help future gastroenterologists.
Trainees usually spend a year in each centre. This means it's difficult for them to establish follow-up of patients in most cases. What we recommend is that the trainees keep a log of 10 patients throughout the year, perhaps concentrating on follow-up of those with chronic disorders such as inflammatory bowel disease and chronic pancreatitis. This will allow them a better understanding of the long-term consequences of these disease processes.
A lot of gastroenterology trainees are attracted to the discipline because of endoscopy. So what I'd like to propose is that our trainees have an intensive endoscopy week where they spend up to 10 sessions in 1 week purely doing endoscopy. I was very fortunate to have exposure to such intense training myself in colonoscopy at St Mark's Hospital, and I really felt that my skills improved exponentially during that week. So I'd like to offer our trainees the same sort of deal locally. The BSG offers funding opportunities to develop endoscopy services in low-income countries, and I think we can use those for trainees to carry out some upskilling training themselves. So we're developing links with other countries to facilitate that for our local trainees.
Mentorship is important for trainees, especially in the first and second year of training. It helps them identify their personal development needs and also any research opportunities available in the region. We would therefore recommend a formal mentorship program, especially for trainees in early years of their training.
In Shropshire, we've always tended to get trainees quite early on in their training programme, typically ST3s. And what we always try and emphasise is that although there's a natural tendency to want to learn lots of clinical knowledge and lots of new skills, particularly endoscopic, this is the beginning of training to be a specialist for the rest of your life. And actually, the difficult things when you become a consultant are not necessarily around clinical knowledge and skills, but they're about how do you manage your practice, how do you organise your programme of activities, who do you see in clinic, who do you organise a test for before you see in clinic, do you organise follow-up appointments when you organise tests, do you look at test results first, how do you manage people with cancer who aren't going to go and see an oncologist or a surgeon, how often do you see them, will they feel abandoned if you don't see them? If you keep calling them back to hospital, will they feel it's an unnecessary burden when they're feeling frail and weak and uncomfortable? How do you communicate with colleagues? How do you put together a business plan? How do you manage disappointment when when you want to take a service in a particular direction and you're having difficulty doing that. It can be a real shock when you become a consultant, and those are the things that trouble you the most. And what we try and emphasise right from the very beginning, because we tend to get trainees right at the very beginning, is that's something to think about right away. Beginning in clinic, how are you going to take this patient through the process of seeing a doctor, having tests, and finding out the answer. And we hope that in that way we give trainees a great start to their training, so that they recognise from the beginning it isn't all just about how many endoscopic procedures they can carry out. Thank you very much.